Good morning. Welcome back to Passionate World Radio Network. To become successful, one must put themselves in the path of a giant. Passionate World Radio Network. And this morning at 11, on LIllian's interview, our special guest today is Cheryl A. Pruskowski, who is an oncology nurse navigator with Brandywine Hospital. And she brings 20-plus years for care as an oncology nurse at Brandywine Hospital. So good morning, Cheryl. How are you today?
Good morning. I'm fine. Thank you for having me on your program this morning.
Well, I'm really delighted that you agreed to come on because everyone knows that breast cancer is still a big cancer in our society, and that if it's not discovered early enough, the consequences can really lead to trouble.
They can, and you said the right word in saying early, because that's really the key word, that all of the education is leaning towards early detection, early findings of these masses or cancers, and that all begins with women being aware of their own bodies. Breast cancer in American women, except for skin cancer, is the most common cancer in American women. It is the second leading cause of cancer death in women, except for lung cancer, which kills more women each year. There is a 1 in 8 chance that a woman will develop breast cancer in her lifetime. That's the bad news, that the cancer is still out there. We still have to make sure we're taking our personal responsibility and action and being responsible for our screenings. The good news is that from 1989 to 2015, the death cancer rates have dropped 39%. That's a huge decrease in cancer death rates. There's been an increased awareness, earlier screenings, and improved treatments that have led to that 39% drop in cancer death rates. Women are surviving breast cancer. Women are being treated. There are many who have completed treatment. There are many that are now considered cured. And that's a word that we didn't use 10 years ago, but we now have women that are cured. The women with earlier stage cancers have a better survival rate. The American Cancer Society published breast cancer survival rates by the stage of cancer. And that's with stage 0 or stage 1 breast cancer, there is a 100% 5-year survival rate. And that's 0 or stage 1. So those are those cancers that are found very early on. And that's very small, very early on. With stage 2 breast cancer, the 5-year survival rate is 93%. With stage 3 breast cancer, 5-year survival rate is 72%, but these women are often treated very successfully. With your patients in stage 4, that's metastatic breast cancer, that's a little harder to treat, and the survival rate is 22%. There's currently many treatment options that remain available for this stage of breast cancer, and the staging system was based on pathological stages, a physical exam, biopsies, imaging tests, and results of surgery. And the American Cancer Society recommendations for the early detection of breast cancer is to make sure that we find the breast cancer early, finding it before it spreads, when it's still small, when it's easier to treat successfully. So how can we do that? Well, the recommendations continue to be know yourself. Look at your breasts in the mirror. What do they look like? Are there any changes? Examine your breast monthly by lying down on your bed. Examine your breasts, starting from the outside in a circular pattern, and that includes underneath the armpit where the lymph nodes are, and going around in a circular pattern, all the way circular around to the nipple area. And doing this monthly, and I always say use your birthday day number, unless of course you're a 31 and there's not always a 31 in your birth in the month. Then go to a 30, but using that number is helpful. But noting any changes, and then those changes should be discussed with a healthcare professional. Regular screenings. So then knowing how often, when do you get your regular screenings? And that's different. So recommendations for women at average breast cancer risk, and that an average breast cancer risk is those women who have no personal or strong family history of breast cancer or a genetic mutation known to increase risk of breast cancer, such as the BRCA gene. So age 40 to 44 should have yearly screening is optional. At the age of 45 to 54, there should be yearly screening. 55 and older, you can change that to every other year or continue yearly screening, but it should continue as long as women are in good health with a life expectancy of 10 years or longer. Now, these, again, I'm going to stress are the American Cancer Society recommendations, and I often, in speaking in the community, I've spoken to groups of elderly women who might be in their 80s, and they're like, well, my doctor says I really don't have to get a mammogram anymore. And I said that is a very much a personal decision. You do need to have a conversation with your doctor regarding that, but it is their choice. And I want to make sure that everyone is empowered to make decisions and educated to make their decisions. I have an uncle who is 101 years old. He is living by himself. He takes walks every day. He's independent. Now, if he had had cancer when he was 80 years old and had not gone for his screenings regularly because they thought, oh, well, you're 80 years old, you don't need screenings anymore, and he stopped getting screenings, he probably wouldn't be 101 living by himself. So continuing your screenings is a personal decision you make, but it's as long as you're in good health, continuing your screenings and then asking yourself, what would you do if you find something? And with breast cancer, there are different treatment options. We have families that make decisions for with their family members. It could be that they opt for treatment of removing the cancer and then decide either not to continue with further treatment being radiation or chemo or hormone therapy, or just choosing one or two of the above treatment options or all of them. The important thing that I'm trying to express here is that each family member and each patient is educated and empowered with the information to make the decisions, to understand the treatment options, and then first to understand the diagnosis, then understand the treatment options, and then to make an empowered decision. And more often, that decision-making is falling to the patient. And that's really where my role as a nurse navigator comes in, is to ensure that my patients are informed, that they assess their understanding, not to make their decisions for them, but do they understand, and what can I do to facilitate further understanding, and then to empower them to make decisions or to assist with their families to make decisions. So research is clear that women who have regular mammograms are far more likely to have breast cancer found early, are less likely to need aggressive treatment, and more likely to be cured. So women need to be familiar with how their breasts look and how they feel, and if there are changes, report these changes to their health care provider as soon as possible. And then, but for women of high risk, those screenings should start at the age of 30. And those screenings should also include an MRI. as well as a yearly mammogram, not instead of a mammogram, but both a mammogram and an MRI. So what is a high-risk woman? That's with a strong family history or a known BRCA1 or BRCA2 gene mutation, where you have a first-degree relative with the BRCA1 or 2. You've had radiation therapy to your chest between the ages of 10 and 30 years of age. So the American Cancer Society does recommend against MRI screening if the breast cancer risk is less than 15%. So it's not a necessary screen if you have a low breast cancer risk. Your screening should continue to be your mammograms. If an MRI, it's important to remember not to think that the MRI replaces the need for the mammogram. So I know there's a lot of questions on let's all just talk about 3D imaging and how is that 3D imaging different from a mammogram? Well, 3D imaging was approved by the FDA for an advanced technology. 3D imaging provides multiple images or X-rays of breast tissue, creating a 3D picture of the breast. It's different from traditional mammograms, and the traditional mammogram provides a single image. The 3D image provides a clearer image of any breast masses and is easier to detect breast cancer. And, it's important for me to say that men can also get breast cancer. It's not as common as it is with women, but it would be the same diagnostics. It would still be a mammogram. It would still be felt by self-examination. If any lumps are felt in the male breast or axillary underneath the arms, that should be reported to their healthcare provider, and it would be a mammogram that would be needed. And then, of course, if anything is felt suspicious there, the next step would be a biopsy. And then people want to know what a biopsy is and why is that needed. When a mammogram is abnormal, the next radiologist comes and informs the patient that the mammogram was abnormal, that their recommendation is for a biopsy. What that means is that they're not able to complete their report. They see something within the imaging that they cannot determine what it is without getting more information. When you go to your primary care physician for a physical, your doctors often ask you for a blood test to go and so they know what your liver function is or your kidney function is, so that they can get information on how your liver and kidneys are functioning. Without that blood test, they don't have that information. Without a biopsy to know what kind of tissue that is, they don't know what they're looking at. So biopsies are, in our facility, which is our medical director, is Dr. Timothy Fox. He has set forth a practice where when the radiologist recommends a biopsy, he asks that the woman be referred to a breast specialist, someone who will look at the radiologist's report, look at the radiologist's imaging, assess the patient, determine the need for further diagnostic testing, including a biopsy, and will determine what type of biopsy would be appropriate. And there are different types of biopsies. But the biopsy will take a small amount of that breast tissue from the suspicious area, and it will be looked at underneath of a microscope by a pathologist, and then they will be able to tell you exactly, or tell the physician exactly what type of tissue that is. 80% of the time, it's benign, meaning not cancerous. But 20% of the time, we find a cancer. And when we find that cancer, that biopsy would tell the physician what type of cancer it is, and then they will know the next steps for treatment. So that's a little bit about a biopsy, and then they'll know what the next steps are for the particular patient. How does that affect the patient and family? Well, that's really why I was brought in to be the navigator here at the Brandywine Hospital. As soon as a woman is told she's had an abnormal mammogram, even without a diagnosis of cancer, her stress and anxiety have increased significantly. And my job is to try to reduce that, to try to help them be educated, to understand, but mostly to hold their hand through the process so that they're not alone. It's a very scary process, and hopefully to expedite the process as quickly as we can so we get answers. And once we have the answers, then the patient and family members can have information to make further decisions, and hopefully, fingers crossed, and a little prayer, they'll be able to have good information and we'll be able to say that it's benign, and we'll see them for the next mammogram.
Thank you, Cheryl, for sharing all this information. And ladies and gentlemen, if you want to hear all this information and contact from Cheryl all over again, you can listen to this stream over at https://passionateworldradionetwork.com or iTunes or TuneIn or Facebook.com/PWR Network LLC or Twitter.com/@Caldwell, CAULDWELL. If you have any questions or you want to talk to Cheryl, you can reach her at, what is your email, please?
My email is Cheryl.Pruskowski, PRUSKOWSKI, at Tower, TOWER, health.org. I just need to correct one thing, Mrs. Caldwell, if I may. My experience in nursing was not 20 years in oncology. I need to correct that only because in respect to the oncology profession, I worked in case management in oncology for 1 year, but my experience in nursing has been surgical trauma, ICU, cardiac nursing, and transplant, and then case management, with 1 year working in oncology before being asked to be a navigator. So in respect to my colleagues in the oncology field, which is very specialized, I need to just correct that. But I thank you for your time and for having me on your program.
Well, thank you very much for showing up. We'll certainly ask you back to discuss some more topics about breast cancer and breast cancer awareness. It takes a lot more than just running 4 or 5 miles to earn money for cancer, and there's a lot of things that need to be said, especially for women, for example, who have had their breasts removed because cancer seems to be very prevalent in their family, especially breast cancer. And I can't imagine what kind of effect that really does have on them, since our society is very breast conscious.
Well, thank you, and I'd like the opportunity to come back and speak with you again about things that we can be doing on a personal level to take action to prevent cancers that we now know through research are showing some positive trends towards reducing the incidence of cancer. So perhaps another time.
That would be terrific. And for folks who want to know, my mother had breast cancer. She chose not to have, she had one breast removed, but she chose not to have the reconstructive surgery. She was given 6 months to live, and she lived 15 years additionally.
Isn't that wonderful?
Yes. But then on the other hand, my husband's sister was diagnosed with an advanced form of breast cancer, and within 6 months she was dead. So it's something that you really do need to stay on top of. And gentlemen, you need to learn how to check your nipples and be just as careful, because if cancer is in your family, then it's in your DNA, and it may skip you to your children or your grandchildren. So in any case, you need to be aware. So before you go away and stray, I have this little blurb about energy from Emerson, who says, the world belongs to the energetic. Thank you all very much for listening, and remember, please keep listening.